Our next topic for medical emergencies is gastrointestinal and respiratory disorders. These topics correspond with Chapter 13 in your medical emergencies book. First, we're going to talk about gastrointestinal disorders. So, on the back side of the medical history form, these will be found starting with eating disorders and going down through the list through ulcers. For this course, we're going to focus on gastroesophageal reflux disorder, or GERD, peptic ulcers, and finally malnutrition and eating disorders. Gastroesophageal reflux disorder, also called GERD, and also known as acid reflux or persistent heartburn. And this is a condition where the gastrointestinal fluids or acids flow backwards into the esophagus, and usually this is due to the sphincter that controls, that regulates the fluids between your esophagus and your stomach. It's weakened, so instead of preventing it from flowing backward, the weakened sphincter allows it to flow backward into that esophagus. And these stomach acids, they irritate, they cause inflammation, and they ulcerate sometimes the lining to the esophagus. And because this is all happening, that inflammation and ulcerations, it results in pain and sometimes a burning sensation in the middle of the chest. This burning sensation actually can sometimes mimic the symptoms of a heart attack. So a lot of times patients will feel this mid-chest burning or pain, and they'll think that they're possibly having a heart attack. So you need to be able to have the patient distinguish between something like heartburn or actually having a heart attack. It is the most prevalent GI disease in the U.S., and some of the symptoms with GERD include burping, cramps, flatulence, feeling of fullness, obviously also the burning in the chest. And these symptoms can also be exacerbated. So if a patient eats a large meal prior to coming in for their appointment, and also laying in the supine position, which is the position that we put our patients in for treatment. So we're already putting them in the supine position. We have to treat them in some kind of position, laying back, but we can prevent them from eating large meals, and that can help tame their symptoms during our treatment. So GERD is treated by over-the-counter medications, and there are some prescription medications. So you may have heard of some of these. Prilosec, Zantac are pretty common over-the-counter. Reglan and Dexilant are some newer prescription drugs, and also something like an antacid, Tums, can be used to help control GERD. Here is a depiction of gastroesophageal reflux disease. So in a normal, healthy patient, the esophagus and the stomach are connected and closed off by a sphincter. And in GERD, that sphincter is weakened, it has many micro openings, and the backflow of fluids from the stomach can go into the esophagus. The next GI disorder we'll talk about are peptic ulcers. An ulcer, in a generic term, is an erosion on the surface of tissue. And when that erosion is located in the esophagus, stomach, or duodenum, it's considered or referred to as a peptic ulcer. The main cause of peptic ulcers is Helicobacter pylori. This is also known as H. pylori. And in 75 to 90% of peptic ulcers, this is the cause of it. And what H. pylori does is break down the barriers that line the intestines. Those barriers are protecting the intestines from acid erosion. So when H. pylori comes in and breaks down that barrier, then the stomach acids, or those gastric acids, can break down the lining of the intestines and ulcerate that epithelium. So you can see in the picture to the right, we're looking at a picture of the stomach, and several areas we're seeing those ulcerations where the lining of the intestine, the epithelial layer, is eroded. In the stomach, it's called a gastric ulcer. In the duodenum, it's called a duodenal ulcer. In general, a generic term for any of those areas is a peptic ulcer. They also can be caused by other things other than H. pylori. This could be just having excessive acid in the stomach. Someone who takes a large amount of aspirin or NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs. This is something like Advil, Aleve, there's a few other ones. And taking large amounts of those medicines can break down the stomach as well. And smoking and alcohol can also cause peptic ulcers. And when patients have these, they're treated by antibiotics, and the symptoms are lessened by GERD medications. Clinical applications of GI disorders. So why, as oral health care professionals, are we concerned about GI disorders? First, we think about patient comfort. So these patients might be more comfortable being seated in a semi-supine or semi-upright position. We talked earlier about how being seated in the supine position can exacerbate those GERD symptoms, the pain in the chest. So if we're able to treat them in a semi-supine position, that might alleviate or reduce the amount of symptoms that they have. Patients might also want to be repositioned to the upright position periodically so that they can reduce their symptoms if that's something that might help them. Another concern we would have is erosion of enamel. So if you think about patients that are constantly having acid reflux, they're getting those gastric acids into the esophagus and potentially entering the mouth. So we're changing the environment of the mouth to be very acidic. And acid erosion starts at a 5.5 pH. And if patients are constantly having an acidic pH in their mouth, they're going to get erosion of their enamel. So for these patients, we may want to consider encouraging them to do a fluoride therapy. This might be something just as simple as a low dose daily fluoride rinse. Also, these patients, we most likely don't want to prescribe them aspirin because of the acid content. So we think about what aspirin is. It's acetylsalicylic acid. So it's acidic in nature, and we don't want to add that to their already acidic environment. So for dental pain, we can manage that pain with acetaminophen or Tylenol. We should consider scheduling appointments at least 3 hours after a meal. We talked about how large meals can exacerbate their symptoms, so if we can choose to either schedule them mid-morning or mid-afternoon, or around how their schedule works as far as their meal schedule. And finally, if their reflux is severe enough during an appointment, the patient might decide to discontinue treatment. And at first, when I first started teaching this class, I thought that was a little bit dramatic. But I recently, maybe about a year ago, had a patient that did have severe acid reflux during her appointment. It occurred after we were finishing with her prophylaxis treatment, and I was taking a couple x-rays on her, and it was so severe that she just could not move on. And I truly believe that she was having a lot of severe pain. And we came to figure out that she usually does not eat before her appointments, but because she was taking a pre-med, she took pre-med because she recently had a knee replacement, I believe. She decided to eat right before her appointment to take the pre-medication, and she thinks that's the reason why she was having such bad acid reflux sitting in that supine position. So I did think it was dramatic, but now going through experience on my own, I can see the reality that patients would potentially need to reschedule their treatment if they were having acid reflux that bad. We're also going to briefly touch on malnutrition and eating disorders. When we think about malnutrition, we're usually thinking third world countries, people with low socioeconomic status, very poor countries, not typically the U.S., but when we do see true malnutrition in the U.S., it's usually the result of an eating disorder. Some quick facts about eating disorders. They are most common in adolescent or young women. It's not as common in males, but there is a rise more recently in the amount of males with anorexia. And there's two main conditions when we talk about eating disorders: bulimia and anorexia. Bulimia is characterized by abnormal, excessive eating that's usually triggered by some emotional distress, and it's followed by purging or vomiting. Anorexia is a suppressed desire to eat and basically starving oneself. Sometimes people with anorexia will also show signs of purging. This slide shows some depictions of bulimia. So on the last slide we talked about how bulimia can cause perimolasis. Perimolasis is, if we take it into separate words, peri meaning around, mole meaning molar, and lysis meaning to dissolve or to loosen. So basically it is dissolving or eroding of around the molars, but it can be around any teeth. So with bulimia, we see this because of the excessive purging, the excessive gastric acids that are passing through the mouth, and also the general acidic pH that keeps in the mouth for a long time. So typically you'll see this on the lingual surfaces of the maxillary anterior teeth, and that's what that top right photo is showing. But it can be anywhere. The middle big picture is showing some erosion right there on numbers 8 and 9 towards the more apical thirds of the teeth. And also in the top left picture, we're seeing the thinning of the enamel of 8 and 9. So right at that incisal edge, there's a lot of thinning. So it's a lot of times hard to recognize someone with bulimia because they're usually of a normal weight. So someone with bulimia might show these oral manifestations, and it's not always just because you see this erosion of the enamel. It doesn't automatically mean the person has bulimia, but if they're falling into the population of young women or adolescents that might be at risk for bulimia, if there's other things that you notice about a patient that might point you towards that they might be bulimic, knowing those signs and being able to potentially discuss that with the patient can potentially save a life. So this is something that we need to be on the lookout for as healthcare professionals, because being able to recognize this, sometimes that's all it needs for someone to get help if they have an eating disorder. Anorexia is a little different because we have this suppressed desire to eat. These people have an intense fear of gaining weight, so for that reason they starve themselves. They also can have body dysmorphia, so that's what that middle picture is showing: a very thin person looking in the mirror and seeing someone who in our eyes is very average, but in her eyes is big. So patients with anorexia aren't going to necessarily have the same oral manifestations as bulimia unless they are also doing the purging, but they are going to have some other health concerns that we need to be aware of. So our clinical applications for eating disorders, bulimia, we're going to look for the oral manifestations. Other than erosion that we saw in those earlier pictures, they might also have mouth sores and potential caries and tooth sensitivity. So this is all due to the erosion. Again, the most common place to see erosion in bulimia is the maxillary anterior linguals, and these patients may benefit from doing that low dose daily fluoride, either with toothpaste, with fluoride in their mouth rinse, or potentially other recalcifying agents that we can give our patients. And with anorexia, not necessarily any oral signs, but we are going to monitor their vital signs. These patients might tend to have slower respiration and heart rates. And as a general systemic, they also can have heart muscle damage, electrolyte imbalances, weakness, fatigue, and the potential for loss of consciousness. So we should be aware if we see a patient that appears to potentially be anorexic, that could be some concerns that we would have during the appointment. Our next topic is going to be on respiratory disorders. So again, we're looking on the back side of the medical history form and starting with asthma and then bronchitis and emphysema. And for this class, we're going to focus on asthma and COPD, which includes bronchitis and emphysema. And we're also going to include some information on airway obstruction, which is not found on the medical history form. Asthma is a condition that is characterized by the body having an increased responsiveness to a variety of different kinds of stimuli. This responsiveness is constriction of the trachea and the bronchi in the lungs, and that makes the airways more narrow and makes the person have difficulty breathing. So in asthma, the symptoms can be coughing, shortness of breath, feelings of chest tightness, wheezing, and potentially normal to elevated blood pressure and increased heart rate. The triggers or those stimuli for asthma can be a lot of different things. Allergies are pretty common, so things like dust, mold. So they're not having an allergic reaction that's stimulating maybe skin, but they're having that bronchoconstriction, that respiratory issue. And that's similar to what we talked about when we talked about allergies a few weeks ago. But it also can be stimulated by anxiety and stress, and also exercise as well. So some people have exercise-induced asthma. And when people have asthma, it is treated with what are called bronchodilators and or corticosteroids. A subset condition of asthma is called status asthmaticus. This is someone that has asthma that does not respond to medication. It's considered unresponsive. So someone who's having that bronchoconstriction, the narrowing of the airways, that does not respond to those bronchodilators or corticosteroids. These people also will have repeated attacks without being able to recover in between. So they're constantly getting these asthmatic attacks, no recovery, no responding to medication. So it's pretty severe, and these patients, if you probably would never come encounter with them because they're going to be seen in more of a hospital setting where it can be much more controlled than we have in the dental setting. Patients that have asthma will be treated with two different types of drugs. First is called bronchodilators, and these are inhaled drugs that are used to directly combat bronchospasm. So bronchospasm or bronchoconstriction means the same thing. We're having constriction or narrowing or spasming of the bronchi in the lungs, and they need to be dilated by a bronchodilator. What that drug does is relax those bronchioles so that they're not constricted, they're not as narrow. Common prescriptions that you'll see are albuterol, so someone might call it an albuterol inhaler. And then brand names of albuterol inhalers are ProAir and Advair. There's also corticosteroids. So these, they don't directly combat the bronchospasm, but they combat the inflammation that also can be symptomatic in asthma. So that can reduce these corticosteroids can reduce the symptoms of asthma. And there's also some corticosteroids that are inhaled, just like a bronchodilator is. Corticosteroids are pretty powerful, but oftentimes have more systemic side effects, especially the longer you use them. So a lot of people that are doing inhaled corticosteroids might have dry mouth from it, and that would be applicable for something for us to know. So common prescriptions would be prednisone is a common one, and an inhaled corticosteroid that you might see is Symbicort. When a patient marks yes that they have asthma on their medical history form, we need to make sure we're asking the appropriate follow-up questions so that we are doing our best to prevent any kind of asthma attack in our chair. So first thing we need to know is, when was their last episode? When was their last asthma attack? This will help us determine how frequently they have asthma attacks. So some people have them very infrequently. Some people have them once a day, and they need to be constantly carrying that asthma inhaler with them. What triggers the attack? So is it when they are running around and it's with exercise, or is it when they run into a attic that's full of dust or a field of grass? Is it an allergic response? Or is it something like emotional? Is it stress related? We need to know what triggers the attack, so that if it is something that we can control, that we're doing that. And what medications do they use to resolve the symptoms? So are they someone who only uses their inhaler as a rescue inhaler when they have an asthma attack infrequently, maybe when they're exercising? Or are they someone who regularly uses their asthma inhaler 2-3 times a day, be it a inhaled corticosteroid or a bronchodilator? So how often are they using that medication, and what kind of medication is it? And the biggest question is, do you carry an inhaler with you at all times, and do you have one today? In the case that you had an asthma attack today in my chair, do you have your asthma inhaler out? And a lot of times we'll have the patient actually get the inhaler and put it out in the open so that we can see it. So in the case of they're having an asthma attack, we don't even have to go look for it. It's already there in front of us. So as far as ASA classifications go, a patient would be considered an ASA 2 if they're just a typical asthmatic that doesn't have frequent episodes and that responds very well to their medication. So they don't have it that frequently, and when they do, it's controlled very easily with either a bronchodilator or corticosteroid. And then an ASA 3 would be someone who has exercise or stress, anxiety, and fear induced asthma. So these people, we're going to make sure if we know that it's a stress, anxiety, or fear is a trigger, that's something that we can control as healthcare providers. We can try to employ those stress reduction protocols so that we can avoid those triggers to not have them be stressed or fearful and have an anxiety attack or a asthmatic attack. And we also may want to consider, if there's someone that's very, very fearful to the point where we can't get them to trust us and control us, we can consider something like nitrous oxide or potentially sedatives so that we can reduce the stress chemotherapeutically. In the case that someone does have an asthma attack during treatment, we should be able to manage it. So first, we need to be able to recognize the signs of an asthma attack. You should already know if the patient does have asthma, that could be a possibility. So you should be on hyper alert for that anyway, but to recognize the signs, if someone starts having a cough, sweating, tightness in their chest. You can hear them have difficulty breathing by that wheezing noise. That might be indications that they're starting to have an asthma attack. First thing we're going to do is stop dental treatment. We don't need to continue if this is happening. Position the patient upright, and we're going to be administering that bronchodilator. If the patient has their own bronchodilator, if they have that rescue inhaler with them, they should be administering it to themselves. They should be able to get their inhaler and take that puff on their own. So we're not administering it. They have it. It's theirs to administer. But we also can bring over the oxygen tank to them and have them breathe 100% oxygen. If the symptoms do not resolve after the first dose of bronchodilator and oxygen, we need to start activating the EMS emergency responses and calling 911. And as always in any kind of medical emergency, we're going to document the time, the duration it lasted, the treatment we did to help the patient, and how it resolved, whether it was resolved in the office or if the patient had to go to the emergency room. Moving on to chronic obstructive pulmonary disease, also known as COPD. COPD is actually a group of diseases, but they're characterized by obstruction of airflow and shortness of breath. So the two diseases that we're going to talk about are chronic bronchitis and emphysema, and those are both what's located on your medical history form. Chronic bronchitis is similar to the bronchitis that we might have when we get sick, but when we get it, it's acute. When someone with COPD has bronchitis, it's chronic. They have this all the time. So this is excessive, tenacious mucus productions in the inflamed bronchial tubes. So in the bronchioles of the lungs, there's excessive mucus production. Because of that, these patients are more prone to bacterial infections further than bronchitis. Patients with emphysema. Emphysema is irreversible destruction of the alveolar spaces within the lungs, and that can result in a collapsed airway. So this is actually destruction of the lungs. And this cannot be cured. It's irreversible. So we can only really treat this with the same thing we treat asthma with, bronchodilators and corticosteroids. A lot of times patients have both chronic bronchitis and emphysema, and I'll also just refer to it as COPD. And the most common cause of COPD is smoking. The symptoms of COPD are very similar to asthma, so we're again going to have coughing, potentially sweating, tightness in the chest, difficulty breathing or that wheezing sound, normal to elevated blood pressure, and increased heart rate. So these patients might always be having slight symptoms, so they might always have sporadic coughing, sporadic difficulty breathing, and then it can be exacerbated at times to where they do need to treat with some kind of bronchodilator or corticosteroid. And the picture on the right there shows just some depictions of COPD, so chronic bronchitis on the top. There's a healthy bronchiole, and then a bronchitis bronchiole, so where there's inflammation and then that excess mucus that's produced in the bronchioles. And then with emphysema, we're looking at the alveoli right there, and then you can kind of see how there's breakdown of those membranes there, so it's damage to the actual alveoli of the lungs. So for patients with COPD, they may always have slight coughing, slight difficulty breathing, but when we start to see signs of actual bronchoconstriction, so either the wheezing gets worse, the coughing is more frequent, and the patient's feeling like they're having a lot of shortness of breath, that's when we're going to intervene and start management of COPD. So again, we're going to stop the dental treatment and position the patient in the upright position. We're going to assess the ABCs: airway, breathing, circulation. Do they have an open airway? Are they breathing, and are they circulating? Do they have a pulse? Administer the bronchodilator, so that albuterol rescue inhaler, and oxygen. So it's the same treatment basically as an asthma attack. We're going to monitor their vitals, try to calm down the patient, and again, if the patient is not responding to the bronchodilator, we're going to start the EMS. We're going to call 911. If basic life support is needed, we're going to start that. As always, we're documenting any kind of medical emergency. Our last respiratory, not necessarily disorder, but concern or potential emergency, involves airway obstructions. This is not included on our health history form because it's something that we can't control, but it is a possibility and a potential emergency that could happen during a dental appointment. So if you think about when we treat patients, we're treating them in the supine position. So we are having, if that poses a risk for the patient to obtain an airway obstruction and potentially aspirate some foreign body object. We already have them in the supine position, so gravity is working against us. If we drop something, it's going to go right towards the back of their throat. So especially when we're working in dentistry, we're moving a lot of small items inside and outside the mouth. Also, when we're working in the mouth, and you guys know this from pre-clinic and working on student partners, saliva is slippery. So when we are moving small things, we also have saliva on our gloves. Things have the potential to be knocked out or slipped out. The patient also can have a very active tongue and can accidentally hit our fingers and knock things out of our hands that we wouldn't have necessarily dropped. The good news is that almost 90% of the time, if something's dropped in the patient's mouth and it's lost, they usually swallow it. It usually does not actually block their airway, or they usually don't aspirate it. So things that are a potential risk for patients to aspirate or get an airway obstruction: a tooth itself. So if you're doing an extraction and the tooth is sectioned, part of it falls in the back of their throat, they can aspirate that. Amalgam restorations, crowns or temporary crowns can slip when you're inserting them. As dental hygienists, we could potentially knock a crown off if the crown was weak, or if there was decay around a crown. The crown might pop off during a cleaning and a patient could aspirate that. If we're taking an impression, the impression material can go down the patient's throat. Gauze, cotton rolls, matrix bands. If you're an assistant, you've probably seen a dentist use a matrix band while they're doing a filling, or endodontic files when you're getting a root canal done. So there's a lot of different things, and that's just a potential list of items, but there's a lot of other things that can be aspirated during a dental appointment. And they can be a partial aspiration or a complete airway obstruction. If an item is aspirated, it can be partially or completely blocking the airway. If it's partial airway obstruction, the object will just be entered the airway and it's only partially blocking those air exchanges breathing. So with this obstruction, you would hear some wheezing. You would see that the patient has some air exchange. They can cough and usually can speak, maybe not very clearly or maybe not as strong, but they usually can speak to some degree. With a complete airway obstruction, there's no air going to be exchanged, so you're not going to hear any kind of wheezing. That's going to be complete absence of sound. These patients are going to use that universal choking sign of the two hands crossed across the bottom of the neck. The patient might become cyanotic or turn bluish purple because of the lack of oxygen that they're receiving. If the airway obstruction is not removed, unconsciousness can occur in 3 to 5 minutes. And again, if it's still not removed, death can occur in just over 5 minutes. There are a lot of things that we do as healthcare professionals to prevent the chance of an aspiration happening. Like I said earlier, there's a lot of things moving inside and outside of the mouth, and a lot of small things that we do all day long. So we need to make sure we're putting the preventative items in order as much as possible so that we can reduce those chances of an aspiration. The first thing we'll talk about is a rubber dam. This is the picture on the top left-hand side. It kind of like a blanket that covers the back of the throat. So it looks like in this circumstance, this person's getting a preparation of number 31. So you can see number 31 is the only tooth that's in the area. So it really isolates the dentist to be working on the one tooth. And there's a rubber dam clamp that's holding the rubber dam just around that tooth and then up and around the throat. So nothing can, if something would break off, if the part of the tooth would break off, or if part of the amalgam when they were doing it, or if they're doing a composite would break off, it wouldn't go down the throat. It would sit there in that kind of catch, that glove. It wouldn't go down the throat. Also, in the same sense, is if you're not doing an isolated area, you can pack the back of the throat. When we do sedation cases and the patient is completely under anesthesia, so there's no chance of them getting anything down their throat when they're asleep, we put gauze packs in the back of their throat so that nothing goes back there, and we don't have to have any risk of that because the patient's not going to be able at that moment when they're asleep to respond and know that they're not breathing. Chair position, especially for someone who might have issues. Older populations have a lot of issues not aspirating, so especially with something just like as simple as water. So seating them a little bit more upright so that we're not, we're having gravity work a little bit in our favor. A dental assistant's a great way to help with aspirations. They hold the suction, and if something would fly, they can hurry up and catch it with the suction rather than letting it go towards the throat. There's also specialty suctions nowadays, and in the upper right-hand corner there is a picture of it's called an ISOVAC, and basically it isolates the back of the throat, and it's also that whole, if you can tell, that clear plastic that's going through over their tongue and into the side of the cheek. It's keeping the patient open, and it's also a high-speed suction in as well. So these are really good for hygienists use these during a lot of procedures, doing sealants or doing scaling and root planing procedures where there's a lot of water flow. These are also great for dentists as well. They provide their own, basically it's an assistant for you without having an assistant because it's retracting the tongue, it's providing suction for you, so it's really good for cases like that. And finally, something like a ligature. A ligature is a piece of thread or floss that can help if something were to fall in the mouth. You can hold it by that piece of thread so it's not going to go back any further. So that rubber dam clip that's isolating that tooth, sometimes what they'll do is put a little piece of floss around that in case when they're putting that on the tooth, it doesn't fling off and fall to the back of the throat. We'll also do that with gauze packs. There's gauze that have a piece of floss that comes out with it so that if the gauze were to go down the throat, we could pull it out with that floss. So there's a lot of different things that health providers will do to prevent it, and prevention is going to be the number one way that we stop the chance of having any kind of aspirations. If a patient happens to aspirate an item during dental treatment, we will have to be able to dislodge that aspiration or airway obstruction. So if it's a partial airway obstruction, we're going to be as non-invasive as possible. The patient will probably be able to speak. There is some airway exchange. We can hear them wheezing, so we know it's a partial airway obstruction. And we're going to see if we can get the patient to cough the object out on their own. So we're going to put them in the upright position, have them lean forward, lean their head forward, and really cough, and cough it up as best as they can. And if they can cough that item up, then we know we're safe. If it is a complete airway obstruction, the patient's not making any noise, they can't talk, they're using that universal choking symbol, we need to start with the Heimlich maneuver. I'm sure you all are familiar with the Heimlich maneuver, but we are going to have a depiction on it on the next slide. If the Heimlich maneuver doesn't resolve it, surgical intervention might be necessary. And finally, if a patient either swallows or aspirates something, we lost something during treatment and it's nowhere else but in the patient somewhere, but they're not showing signs of aspiration. They're not having any difficulty breathing, they're not wheezing, they don't feel like something's stuck in their throat. Even if we don't think that they aspirate it, we should urge that patient to get a radiographic exam because we cannot be sure that they actually swallowed it. It could be aspirated, they're just not having symptoms of it. So the only way to tell if it actually went down to their stomach versus in their respiratory tract will be with a radiograph to be able to show where that object is and if it's safe or if it's in the respiratory tract, because if it's in the respiratory tract, they could have a potential for an issue later down the road. And here is that depiction of the Heimlich maneuver. So the first is to give the 5 back blows. So you're going to use the base of the palm of your hand right in the middle of the back and do 5 strong back blows. And then you're going to be putting your one hand, you're going to make a fist with one hand, wrap your other hand around that fist, and right underneath the rib cage in the mid-stomach region, going to be doing those abdominal thrusts to try to get that person to loosen that airway so that loosen the obstruction so that it comes up and out. I know I mentioned if the Heimlich maneuver does not work, surgical intervention might be necessary to help save the patient. So the surgical procedure would be called a cricothyrotomy, and this is basically where a needle or a sharp object like a scalpel, there's an incision made in the cricothyroid membrane, which is right below the Adam's apple. It's an indented area, and to the right there you can see a picture of that. And basically an incision is made there so that the patient can artificially breathe through that opening, which is below where the obstruction is, where the obstruction that's making them not breathe through their mouth possible. And until that obstruction is removed, they're able to artificially breathe in some manner and get some oxygen through this opening that's made with this incision. So on the next slide here, we will see a short video about how a cricothyrotomy is completed. Alright, so that video was actually from the movie The Heat, and in which there was a officer who thought she knew what she was doing and obviously did not. And so the moral of the story in humor is that we are not performing any kind of invasive procedures or any surgical interventions unless we've been specifically trained to do so. So you really need to know what you're doing, and you can cause some major damage. So leave this up to the professionals. If you see someone that is having a complete airway obstruction, calling 911 and having those emergency medical services there as soon as possible is going to be our best bet at saving this person's life. Alright, so this concludes our lecture. We will have a pop quiz on Wednesday in class regarding the gastrointestinal and respiratory disorders.